Good afternoon and welcome to this, the 27th in the webinar series on COVID-19 organized by the Royal Society of Medicine for health professionals, by health professionals. It's the 27th edition, I believe, and it gives me great pleasure to be chairing this discussion this afternoon. My name is Ike Anya. I'm consultant in public health medicine and curator of Nigeria Health Watch and managing consultant for EpiAfric. And I am very privileged to be in conversation this afternoon with two very distinguished, very experienced people who have a lot of experience on the topic of healthcare and the justice system. And so it gives me great pleasure to introduce for this session, where we're going to be looking at the impact of COVID-19 on prisons and other secure facilities, taking quite a broad view in that. And it gives me great pleasure to introduce, first of all, our first panelist, Kate Davies, CBE, who is the lead commissioner and national director of health and justice, armed forces and sexual assault referral centers for NHS England. So not very much on her plate then. She's responsible for commissioning services in all the over 100 prisons in England, as well as the immigration centers and the sexual assault referral centers. So it's a great pleasure to have you on,
Thank you,
Kate, and I look forward to the conversation with you. And alongside Kate, we've also got Dr. Éamonn O'Moore, who again is someone with a lot of experience in health and justice. I was saying to Éamonn just a few minutes ago that as a registrar in the southwest of England many, many years ago, I remember him coming to do a session on health and justice for us. So it's a pleasure to be back here and to see he's still actively working in that area. So do feel free to ask questions. There'll be the Q&A box. We're going to run this with an opening discussion between me, Kate, and Éamonn, and then we'll open it up wider for questions from the audience. So do save your questions, make notes as you go along. The issue of COVID-19 in health, in justice, is a very important one. You know, it's often an area that even in normal times is marginalized and not enough attention is paid to. And so when things get tough, there is a tendency for them to be even more overlooked. And of course, there are peculiar circumstances, which I am very familiar with, having recently worked on some prison outbreaks, about things you can and can't do in relation to control measures that you would ordinarily do. And so it's a very challenging setting, and it'll be interesting to hear what our two panelists have to say about it. And so on that note, I'd like to go straight to Kate and ask, you know, it's been quite a year for everyone, I think, all over the world. But as I said, you know, prisons and secure units, particularly even more challenging. So I want to know, what has the last year been like, looking at, you know, prisons and secure facilities in England, and what has gone well? You know, what are the things you're particularly pleased you were able to achieve? What are the things you think you might do differently were you to be in the same situation again? And finally, are there any things that have surprised you that were unexpected at all? Over to you, Kate.
Okay, so I'll start the ball rolling, and I'm sure kind of Éamonn and I'll do a bit of a double act all the way through, because I think that's kind of basically what the last year has been about. There's no way in a normal period of time that you can deliver, commission and provide healthcare services across prisons and immigration removal centres, children secure units, without doing that 100% in partnership. And so I think what worked well right from day one, when COVID became a global national priority, was that we already had in place the formal partnership agreements with the MOJ, the Ministry of Justice, Majesty's Prison and Probation Service, Public Health England, and also Department of Health and Social Care and NHS England. So we were already working for many years proactively with the objectives and priorities around health inequalities, the principle of equivalence of healthcare, and how someone else's regime, because we're talking about prisons here predominantly today, I know, when we quite often say, not flippantly, but as a way of kind of really getting it over the line, we're often commissioning and providing healthcare in someone else's backyard. So it was really important that those conversations and the communication about our patient group, the resident group, in a closed environment, and how we prioritised reduction of death, what that meant for staff, what that meant for people, the epidemiology that I'm sure Éamonn will come on to very quickly, that was done to look at what that risk indicator could be as part of COVID-19, was a light bulb moment to go, hang on a minute, this is a massive priority in the way that we do things alongside the NHS, of which I am very proud to be a director in, alongside our clinical colleagues and requirements as we moved into a level 4 pandemic position. But also, as you quite rightly said, Ike, let's not forget prisons, let's not forget people and what we've got to do differently. So I think the big challenges were about how we move very quickly into a position of, in some respects, shutting down prisons, what that meant for movement, what that meant for social distancing. We were already working in an environment where, you know, arguably too many people are sharing small environments, small cells, what that meant for staff, how we were looking at different policies, because actually, even in pandemics, you still got people coming in with particularly very serious offences into the prisons, how we got the reception prisons, the trainer prisons, the resettlement prisons, working together around what we now know and affectionately call reverse cohorting around the needs and requirements. But ultimately, I suppose what I personally am very proud of in the way that we've led all of our healthcare commissioning for many years is that, one, we have healthcare services in every single establishment run and commissioned through NHS national and clinical standards, 24/7 as far as its position, and you know, the amount of work that staff have done around the clock as incumbent and increased providers, standing up as it has in every other part I know of the NHS. And we often see that around hospitals and GPs and care homes, etc. We don't often see, you know, someone championing the fact that healthcare services and staff and clinicians and nurses and social workers and substance misusers have been working constantly through the pandemic, above and beyond. And then the other big and important strength, like, has been lived experience, working with our patients, working with the men and women, working with the children and people, working with the voice of, and going, how does it feel for you? What can we do when you are maybe locked up for longer periods of time within your cell, when we are looking and working with people who still, like in every community, are concerned about the lump on their breast or their groin, they're concerned about their mental health, their medication, detoxing from substance misuse, what that means when you're looking at, obviously, maybe long-term conditions that you're nursing, end of life, as well as COVID and infection control. So those are all the challenges. But I think what we did well, and probably this is maybe the time to hand over to Éamonn as well, just kind of put it in context before we kind of go on to the kind of the longer term issues, is outbreak control. Because what we were doing was responding daily, hourly to COVID infection, outbreak controls, working with Public Health England, with our prison service colleagues, with our governors, with our prison officers, with our clinicians, with our healthcare teams, with our commissioners, to then stand up outbreaks to manage to support hourly, daily, weekly responses to outbreaks and to infection and to death. but actually also to minimising and reducing risk, but also carrying on, to put it bluntly. We needed to look at what that meant, like with all parts of society, around women, around different needs, around age, around long-term conditions, about vulnerabilities, about shielding, what that meant for Black and minority and Asian communities, what that meant when you've got someone that's on dialysis. You know, we run healthcare services like a mini community. We have to have a full range of healthcare services. And like the community under level 4, we also had to stand down or slow down some of those services. So those were the balances. That probably, as a question around what was surprising, was surprising that we actually were keeping those going as much as we could 24/7. But I think the surprising element was how we managed to influence, and I shouldn't really say this really, should I, Emma? Because we've been doing it for so long, I don't know why I should say this really, but managed to influence government, particularly, you know, Éamonn particularly, but both of us are sat around, you know, cabinet tables and Secretary of State to say, hang on a minute, this patient group, this population is really important. However, I will just finish with my last, I'll come back on this, Ike, I'm sure, because this is kind of the flavour really. It has been, and it continues to be, a challenge to get the understanding of equivalence, what that meant for PPE, what that means for mass testing, what that means for vaccinations, what that means for, you know, kind of now standing back people up into long-term conditions for critical care, waiting times. That's my day job. That's everybody's day job that's working. Hundreds of thousands of people also in health and justice and criminal justice and healthcare. However, what has been disappointing, and unfortunately it's not the surprise, is that we've had to often really, really advocate for this patient group. And I would say, and I know Éamonn will, because Éamonn's been an amazing champion and lead for this, and also within the care home sector. Or, you know, people have run up and down to find out in closed environments what that means for a cruise ship. But let's run up and down and look what that means for the environment of people and people's families that are in prisons and detained in secure settings. So we're still doing that. I'm very proud of the way that the UK and England, particularly when we look at it globally, responds to the needs of its patients in healthcare and equivalents within detained and secure. But COVID has shone a light generally on health inequalities, massively. Let this be an opportunity to learn lessons on health inequalities for our patient group in and out the criminal justice system, but particularly within our adult prisons and children secure and immigration removal centres. So very happy to hand over to Éamonn, who'll probably talk more about the figures and what we were anticipating. But let me just say now, the vaccine programme is running at equivalence in and across England's prisons as it is in the community. And that's, I think, really where I'll come back to in a minute, if that's okay, but hand over with those questions to Éamonn. What do you think, Éamonn? We're often called, do you mind if I call us our affectionate name? We're often called the Cagney and Lacey of the criminal justice system, just for anybody that's on this call.
Right.
We're a bit old to know what Cagney and Lacey
So who's
is.
the good cop and who's the bad cop?
Yeah, well, but I mean, but seriously, it takes that element of, you know, partnership work and response when we are in pandemics for everything. Then look at the layers of what that means in partnership terms for our patients in the criminal justice system. So
I'm very aware of all of that. And, you know, I must say, Kate, you know, I remember the days when the NHS was not responsible for prison services and medical health services. And maybe many people don't remember that at all. And the challenge of even getting to a point where the NHS is responsible for all prisons healthcare is, you know, quite an achievement. And I know how difficult that's been, and the pressures that have been put on. And, you know, there are people who are quite rightly advocating and demanding for more. And that's right, because as you say, it's a neglected and easy to neglect as well population, because it's easy for people to say, well, you know, they're not deserving, you know, the whole question of deserving and undeserving, which is sad. But you know, I'll leave that for further discussion and ask Éamonn to.
I'll come back to that one. I have said to JCBI chairs and others, I am very happy to be the woman on the front page of the Daily Mail. If you're worried about healthcare services for prisoners, I can understand that ethical debate.
Yes.
But I and everyone else, I presume, on this call as part of human rights and humanity, as well as obviously care and rehabilitation, are very proud that we can do this within England.
I mean, that's one of the things I'm hoping anyone who's listening will take away wherever they're listening in from, to sort of become advocates for the healthcare.
Yeah. This is about the care that we all consider as part of society. Yeah.
Absolutely. So over to you, Éamonn, on that note.
Yeah, no, thanks so much, Ike, and thank you for the invitation from the RSM to be part of this very interesting seminar. As a fellow of the RSM myself, I'm very proud to be engaged with it, and I spent many's a long day in the RSM library researching my dissertation for my Master's in Public Health on prison healthcare. So I've had a long association as well as a long association with prison health. The last year has been a very challenging and difficult one for everyone, not least people in prison. I remember last February receiving my first call late in the evening about a possible case of what was then Wuhan novel coronavirus in a prison in the southeast of England, and reflecting on the challenges that we were likely to face going forward. With very much on our minds as we were dealing with the first few cases. But as Kate has said, we had been working together right across our organisations as PHE, NHS England, NHS Improvement, and with policy partners in MOJ and DHSC, and with Her Majesty's Prison and Probation Service, to prepare for pandemics and how they impact in prisons for quite a long time. So prior to the pandemic, we already had advanced plans for managing and responding to pandemics in prisons. Now, of course, they were focused, as the national plans were, on influenza mainly being the threat, but nonetheless, the model of collaborative work was certainly well established, and the actions that we needed to take were understood. At the start of the pandemic, we did some modelling work with our colleagues in the prison service to understand the potential impact of COVID in prisons in an unmitigated situation and reasonable worst case scenario. And at that time, with those circumstances, it was estimated that reasonable worst case scenario modelling predicted around 2,000 people dying from COVID-19 infection and well over 70,000 possible cases. Now, I'm pleased, and the success of the last year has been that we have not seen anything like that number of cases or fatalities. And while each and every case is a great loss and tragedy for those individuals and their families and loved ones, we have managed to protect the lives and health and well-being of many, many people in prisons. The current estimates for deaths of people who normally live in prison is around 125, although some of those will be validated further as further information comes out following appropriate procedures. We've also sadly seen loss of life among our frontline custodial staff, and indeed want to pay tribute, if I may, to the courage and to the professionalism of frontline healthcare and custodial staff and people working in immigration detention and other settings who've managed to deliver care to people that they've been looking after throughout this pandemic to the highest level that we could expect of them, and going way beyond that in many cases. What has been really interesting as well over the last year to reflect on is how the work that we've been doing in England particularly, and in the wider UK, has been a model that has informed international practice. So one of my roles is also director of the UK Collaborating Centre for the WHO Health and Prisons Programme. And we collaborated with WHO to provide technical guidance to the entire global community on preparing for and responding to COVID in prisons. And that was very much based on the work that we had done in the UK. We implemented at very early doors, once the threat from the pandemic was clear, a program of public health measures that included a system called compartmentalization. The idea being that we would create circumstances in which People coming into prison who may be at risk of importing infection into the setting could be appropriately managed in what were described as reverse cohorting units. People who became ill with suspected or confirmed COVID could be managed safely in protective isolation units, and those who were clinically extremely vulnerable could be protected in shielding units which had enhanced levels of biosecurity. Throughout the pandemic, one of the challenges has been the ways in which we can deliver a whole range of interventions, including testing in prisons. In the early days of the pandemic, when testing was incredibly limited, we had to test the first few cases. If COVID was confirmed, then assume that people who met the clinical definition of COVID were probable cases, and that's a standard public health approach, as you will know. But of course, it meant that we weren't able to accurately describe the impact of the pandemic on prisons until we were able to do much more testing. And over the course of the pandemic, we've evolved our testing, including regular testing of staff, regular testing of people who are coming into the prison setting, regular testing of people who are moving across the prison setting, either to other prisons, to appear in courts, or to transfer to the community. And that has enabled us to refine our approaches to prevent and control infection. Through the year, which has been incredibly challenging, we have seen almost all prisons in England and Wales have incidents and outbreaks of COVID. The most significant of those impacts was felt in the second wave, where we saw the devastating impact on the whole of the country from the new variant, Kent variant as it is called, which was more transmissible than the previous strain and also impacted in prison settings as much as in community settings. At one point, we had over 90 prisons in our estate of just over 100 and odd prisons having a declared outbreak. And in some of those outbreaks, we saw very large numbers of people recruited to the outbreak. So sometimes common was outbreaks at numbers of between 50 and 100, but about an eighth of the prison outbreaks had cases of over 100, and some had case numbers of over 200. This is the reality of infection disease control in prisons, where there is a risk of what we've called explosive outbreaks. So in unmitigated circumstances, you can see that. And then the thing that I think has been really positive about this terrible experience has been the way that the whole community has come together. The people in prisons themselves have been exemplary in many ways in their behaviors in supporting control of infection, and have been active agents in protecting themselves and the others they share their community with. The prison staff, the healthcare providers, the other services that are brought into prisons have all worked in partnership to deliver care in very difficult circumstances. And thankfully today, consequent to reductions in numbers of cases in the community and consequent to the work that we've all been doing together, we are now seeing very low case rate in prisons and very low numbers of outbreaks. And where outbreaks are being detected, the numbers of cases recruited much smaller than they had been. So, and there's more to say, of course, in the vaccine program led by NHS England. But it's been a very challenging year. And I was reflecting with my colleagues in Copenhagen yesterday at a WHO meeting of our Health and Prison Steering Group, that some of the lessons we've learned during COVID will need to inform how we build back better, and how we ensure that the health needs of people in prison are part of the wider public health discussion, how surveillance systems need to include what's going on in prison populations, not only to protect those populations, but to inform national strategies and national biosecurity, and how we also understand better the way to support people in prison, coping with both the consequences and aftermath of some of the privations they've suffered as a consequence of the restrictions in COVID, and how we, as we are trying to do in other parts of the community, deal with the unmet need, whether that's about cancer, non-cancer screening, whether that's about other services that have inevitably built up consequent to the impact of the pandemic on health services generally. I'll stop there. Thanks, Ike.
Thank you very much, Éamonn, and for that extensive, and to you, Kate, as well. I'd like to pick up on a couple of things with you first, Kate, and then on to Éamonn. You know, we talked about the challenge, obviously, of trying to implement control measures in prisons. And Éamonn talked a bit about the scale of you know, we're talking about the scale of the outbreaks that have been seen. And obviously, with, you know, having to restrict residents of prisons to sometimes their cells, or, you know, in the way that lockdown played out. Certainly, you know, with some of the outbreaks I was involved in, we're very conscious of the mental health toll that was having on residents. And also, you know, linked to that, you know, I think we had numbers going up in relation to people who needed support for self-harm, and also in relation to misuse of substances as well. And obviously, these were all responses to trying to cope with, you know, what was a very difficult situation. How did that play out for your staff, and also not having access to some of the support services that would ordinarily be in place, as well as the rehabilitation services as well, which obviously are very important in these settings?
So I think going back to the point that I made earlier, I think one of the biggest challenges is keeping the services going to keep people safe, to care for them, but also, I mean, that's a challenge in working in a prison regime anyway. You know, I mean, I've had the pleasure of working and being part of and visiting many of the prisons, and they're all very different. Their physicality, the way that you know, kind of they have, you know, different regimes and unlock sure. Elements of that, you know, positive use of time, as Éamonn and I like to say, as part of, you know, kind of work and rehabilitation and physical and other exercise. And so, you know, you start from that baseline, I think, like anyway, that, you know, kind of mental health, substance misuse, positive use of time, getting to have, you know, as few DNAs, do not attends as possible in a normal regime is something that we've been, you know, improving, but also, you know, challenging constantly. So then you have COVID, and then you have a need and a requirement to communicate both to staff, actually, and to residents, that actually, just like in the community, you got to stay in your home, and your home happens to be a small cell or happens to be the environment you're in. Now, I have to say very honestly that I think, you know, our best advocates for this have been the men and women, the prisoners. You know, prisons may be behind a big wall, but they're still listening to the radio. They've still got the telly. You've got the prison radio. You've got Inside Times. You've got hopefully the comms campaigns that with the prison service and ourselves, we really scaled up to look at that understanding of why we're doing what we're doing. And some of that feedback, and I'm not going to steer away from this, was very positive. Very positive that some people who felt quite intimidated by the regime, bullying, some of the, you know, kind of, I've worked in and out the prison system or criminal justice system, sadly, probably for 3 decades. And actually, substance misuse, commercial global targeting of UK prisons around supply has been a really difficult issue in the last 4 to 5 years. Actually, COVID didn't stop it, but it did decrease actually some of that within the prison setting. And for some of the feedback from a lot of our men and women, they actually had the opportunity to look at a different level of what they were doing and how they were doing it around substance misuse. There was a lot of peer support that really worked really, really well with people. And I was talking to only a woman last week who'd been in one of the establishments, who was saying, actually, I have really high levels of anxiety. This was a really safe time for me, actually, because I didn't have to feel that I had to join in with the melee of a particular, I won't not name the prison, but a particular prison. So there were issues that we shouldn't shy away from on, as Éamonn says, a lessons learned element to this as well. However, I think as time has gone on, then it has been quite stark that the level of lockdown, the level of mental health capacity, what that means for self-harm and anxiety, what that means for substance misuse, what that means for just being able to have, you know, kind of a change of clothes as regularly as you want to, or to have a wash or go down to have a shower as regularly as you want to, has been the sort of dignity and respect issues, which I know the prison services, you know, desperately tried to support, but have been those issues that actually have exacerbated anxiety and mental health. Medicines management has been crucial, obviously in the same way as it is with the way that the GPs have worked around medicines management and online appointments. So one of the real successes of COVID was that I signed off and we stood up, and are continuing to do this as a sustained resource, 2,000 telemedicine licenses. From prison to prison, prison to community, community to prison, primary care, secondary care, mental health, particularly, as well as physical care. And we've been trying to do that, Ike, for 3 years at that level. And we managed to do that in under 3 months. In fact, nearly, I think it was something like 8 weeks, wasn't it, Éamonn? And actually massive thanks to some people that really, really went above and beyond to get that. But that was really important, to get that digital capacity to support the questions around mental health and substance use, physical health, and other elements that were there to look at that need and that requirement. The issue now is, you know, we're very reliant on incumbent providers. They're largely rolling out the vaccination, and I know there's lots of questions on the question box, on the chat box on this. So they're largely rolling out the vaccination, and, you know, at the moment, as of yesterday, I can say that of a population which I think is about 74,000 in adult and children secure at the moment, then 35% of that population has received the first dose. Right. As part of the cohort, as a recording at the moment of cohorts 2 to 10, and obviously we're on 11 and 12 and 13 very quickly at the moment, then we were first dose to 40s and over of 71%, and second doses of 12%, and actually doses declined or not given for first dose of the prison population that was eligible within those cohorts is about 9%. So, and that's vastly better than some areas of the community. Right. We're doing a lot of work around hesitant groups, around confidence, around needs and requirements. That's given us a great opportunity with the vaccine to look at mental health and have those conversations with people about how you're doing, how you're feeling. We've been pushing additional mental health capacity into many of our healthcare current providers. I think the area that goes often untalked about and probably in the hidden element is substance misuse. 80% of our residents are more likely to have some need around drug and alcohol use, and often start also more problematic substance misuse while in prison as well. Yeah. And we know that spice has been a massive issue. But we do need to look at that as part of the government's strategy and understanding the importance that actually if we get it right, we then get the pathways of care right. So the other element that we've managed to do around mental health and substance misuse is, one, stand up more alternatives to custody. This is the other issue. Now, when we talk about prisons, please can we talk about alternatives to custody? Can we please talk about the use and the unnecessary use of short-term sentences, particularly when it comes to mental health and healthcare conditions which are exacerbating people's criminal justice behaviour? I'm not asking for deflection from sentence and due process of the law, but what I am asking for, and what we are asking for strategically, is that COVID and mental health and substance misuse needs that have been exacerbated around the regime and cohorting, as Éamonn's described, actually one of those solutions, as in the Mental Health Act bill and review that Sir Simon Wesley has led, is that actually let's look at how we use custody. COVID can shine a light on that for mental health. So I mean, I will stop now. I mean, obviously I could talk a lot longer and we've got limited time, but I think that's the issues that are absolutely crucial for mental health at the moment and substance misuse. Ike.
Thank you very much, Kate. I was pleased to hear what you said about digital, getting in telehealth. And, what you said about how you've been fighting for years, I felt exactly the same because, as a public health deputy director, spent a lot of time persuading GPs that telehealth held opportunities and being given constant lists of why it wasn't possible or feasible or ethical. And with COVID, it all flipped in, pretty much almost a week. And that was interesting to see. And I'm glad to see that has extended into the prisons. And I think it's great that that opportunity will continue afterwards, because I think that will be a way of improving access. Éamonn, I wanted to bring you in relation, we started talking about vaccines, and I think it's important to try and get there. There have been some questions in the chat. We're not at questions yet, but I thought it might be a good point about whether we should be using vaccines in prisons as part of outbreak management, so ring vaccination, whether we should be going beyond equivalence to vaccinating even younger age groups. What's your perspective, both as an expert and the Public Health England view?
Yeah, thanks so much. So we've been working really closely with JCVI throughout the pandemic. And in fact, we made recommendations to JCVI to consider such strategies as far back as early November. We continue to evolve our data to inform those discussions. At the current time, JCVI advice has been to offer vaccination in line with the community guidance and on those age cohorts, reflecting the fact that the impact is greatest in those age and clinical cohorts of infection. And prisons as a setting, JCVI have not yet advised should be vaccinated in a settings-based approach. We have also been looking at the opportunity to use vaccines as part of outbreak control in a ring vaccination strategy, and many consultants in communicable disease control will be familiar with this as a strategy, both to try to limit the impact of any specific outbreak and reduce the risk of subsequent outbreaks in a population. The challenge we've had with the COVID vaccines are the time to evolve immunity and the utility of those interventions to control any specific outbreak. And in general terms, because there are several weeks required to evolve immunity from the first dose, in most settings and situations, that is therefore not effective at limiting transmission. However, we are presenting and continue to gather data showing that because of the highly compartmentalized nature of prisons, we've seen outbreaks that have lasted many weeks. And there is an argument we would say to consider, given that circumstance, whether there is a role for ring vaccination. But that's an ongoing discussion and debate with JCVI and will be informed by our ongoing epidemiological assessment. The challenge we have at the moment, of course, which is a good challenge to have, is that the number of outbreaks are very low. So assessing the impact of a ring vaccination strategy as a way to control subsequent recruitment of cases is problematic. But the key messages are that NHS England have been leading the implementation of the vaccine according to the age cohorts and achieving high levels of coverage in those groups that have been offered vaccination. The proportion of the total prison population therefore being vaccinated is increasing week by week, and that's therefore getting us to levels near where that coverage starts to be what people would maybe describe as herd immunity levels, although we are a little way off that yet. The program is going at pace, and of course has had to adapt, as all programs have had to emerging guidance, including the use of AstraZeneca vaccine in younger age cohorts and sourcing alternative vaccines and so on. So like other settings, it's challenged. But as a point of principle, clearly the appropriate defense for outbreak-prone settings is to have high levels of vaccine coverage and to sustain those, to take account of changing populations and staff turnover and so on. So NHS really has led the world in delivering vaccine programs to prison populations. Many of my colleagues from other countries look with envy at the approach that they have taken. None of us, Kate nor I, would say that we're complacent about this. We're all working incredibly hard, including the frontline staff who are delivering the vaccinations, to ensure that we get high levels of coverage. We all want to see that happen faster. We all want to get to that point quicker in the same way we do in care homes and in other vulnerable settings. But work is going on at pace, and I think people perhaps a little bit further away from the detail may not appreciate how much of the prisoner population, particularly the higher risk prisoner population, have already been vaccinated, and how much work NHS has done in ensuring that actually the UK, or the English, I should say, programme is actually world leading. Thanks.
Thank you very much, Éamonn. I think it's probably time to take a few of the live questions. I'm starting with one that asks about how, I'm sorry, so the first question I want to take was, what measures have been put in place to support the mental and physical well-being of children and young people in secure settings? And I think there are a couple of questions about bereavement support for people in secure settings who are unable to attend funerals and that sort of thing. And I'll hand that to you, Kate, to perhaps, or Éamonn, whoever feels most comfortable. I think, Kate, would you be happy to speak to that?
Yeah, I know time's against us, so I'll sort of just stick with headlines, but
Sure.
I saw the questions and also the one on the Immigration Removal Centre, so thank you. So
Yeah.
children and people secure is thankfully fairly low numbers. The numbers have got lower during COVID. It's been really important not to incarcerate children and people unnecessarily, but at the same time we have some very complex and kind of young people that are locked up, in inverted commas. We've put a lot of very personal care regimes around those children and young people, and hopefully that sort of really helps with some very vulnerable kids. A lot of the issues around trying to keep young people unlocked much more. The bereavement question is crucial for adults as it is children and young people. It's been one of our biggest challenges around bereavement. I've certainly had bereavement during COVID period, and the equivalence of not being able to attend or to grieve in the same way. Digital support again has been pretty important. There's been quite a lot of work that's been done with children and young people around video stories. I've done some amazing video stories around their lives and their concerns, but we have had a strong end of life program for some time, and so actually bringing what we call stand up and stand down care, and we put in an additional policy actually both in adult and children secure around stand up and stand up care around end of life and primary care intervention, because of many of those issues are in the question. And just lastly, very quickly, on the Immigration Removal Centre question, at the beginning of COVID, there was about 3,600 men and women that were part of detained immigration removal centres. Of course, they are not there as offenders, they are there because of the detainee status of the immigration and migration policies of the government and the Home Office. That number decreased very quickly, and we still have only about 400 people that are still in immigration removal centres. That's been a very positive move on my part. And actually, what has been important is the equivalence around safety care, cohorting, but also vaccinations and outbreak control.
Thank you very much, Kate. I think, one of the most moving moments for me during this pandemic was actually taking part in a review of a death in custody, in hospital, of a person who was in custody, and hearing about how the prison was able to organize a funeral service in accordance with the wishes of the family, that was conducted by Zoom, so that residents and staff were able to take part as well as family. And and the gratitude that the family, a bit from the letter was written. There was also a very poignant and sad bit where in the report that said he had spent most of his adult life in prison. And, that just really was, it underlined the importance of, a lot of the work that is being done and the challenge of doing it in pandemic situations. So, Éamonn, I think, still sticking with some of the questions and the themes coming through, there's also the question of, whether a different strategy should be applied to prisons in relation to control measures generally, given that they arguably are at more risk than outside of prison. I don't know if you have any views on that.
Yeah, I mean, we've been very clear that prisons are a high risk setting for outbreaks, and we've been clear on that from the very beginning. And we've advised government on that point, and the measures that were put in place during the course of the pandemic reflected that concern. And those measures have been supported by the prison service, by the Ministry of Justice, and have often been very difficult. They've included restrictions on populations moving into some prisons with outbreaks, or restrictions on people moving out. They've restricted regimes on the advice of public health to reduce the risk of transmission of infection. They've changed accommodation and changed the way that people move and work within the space. They've changed staff deployment on advice of public health to reduce the risk of cross-deployment, and even impacting on how people live outside of their workplace, such as people in shared accommodation, and considering how that impacts on where they might work within the prison, or how people travel to work, etc. So there's been a high degree of cooperation between the prison service and the public health advice that we've been giving, and of course everything's done in our partnership space. But learning from this pandemic will inform preparation for the next pandemic, and certainly what I'd like to see going forward is the ability to deploy effective levels of testing evolved much more quickly than we'd experienced in this current pandemic to inform control strategies in prisons. Now, the initial issues were often down to just the lack of testing capability and capacity across the whole country, and other priority settings and so on, getting those scarce resources. But we need to ensure that prisons are part of the future system planning for a whole system response to future threats. The other point is that prisons are, as Kate has said, part of the community in which they sit. The people who live there, the people who work there, come from the communities, and there's a high degree of interaction between prisons and communities. So ensuring that prisons are included as part of wider pandemic planning, by definition, rather than, as has sometimes been the case, perhaps coming as a bit of an afterthought, is really, really important. We did have an exercise Cygnus, which was the pandemic plan exercise a few years ago before the current pandemic, prisons included, which I was very pleased to see, and that was down to advocacy from people like Kate and myself and others to ensure that. But undoubtedly, the level of detailed planning that was required, we could only really do a little bit of that. So the learning nationally and internationally from this experience will be important, and has to include developing better surveillance systems to include prison surveillance as part of a whole system understanding of the impact of infection, and considering prisons as potentially places where infections can amplify. And that's an important part of our future biosecurity, recognizing in England and in the rest of the world, prisons can be reservoirs and amplifiers of infectious diseases. The very first public health system in the world was in England, and it was a prison health system designed to protect the community from jail fever. I learned that in the library of the Royal Society of Medicine. Thank you.
Thank you, Éamonn. And that's a brilliant way to conclude. I'll just go over to Kate for her own views of what, in one sentence, if possible, because I've been so enthralled by the conversation, I hadn't realized how far we'd gone with time. So could you just, in one sentence, Kate, give your concluding view of what needs to happen for the future, any lessons to be learned from prisons for the wider community?
Okay, I'll keep it short. So I think COVID has shone a light massively on how important healthcare and health and well-being is as the core of everything we do within the criminal justice system, and particularly within prisons. And for all my health colleagues on this call, and I know there are many hundreds of you, which is really humbling, because I haven't been to the Royal College Society Library, I'm afraid. As a dyslexic woman, I'll make sure I get there. I've got my own library. Please champion that our patients in the criminal justice system are absolutely the reason you get rehabilitation, but the reason we get the right results in pandemics is because of healthcare services. And that for me is absolutely the essential lesson. And it's the same, I have to say, for the needs of rape and sexual assault and victims of SARCs as well, which I know that isn't what this seminar was about, Ike, but is one of the biggest areas of work that also is required to look at itself post-pandemic. Thank you.
Thank you very much, Kate, and thank you very much, Éamonn, and also for your multitasking, answering questions in the chat. Thank you to the audience for your very lively engagement. Apologies, we couldn't take all the questions specifically, but I hope we've answered many of them. It's obviously a topic we could spend a whole day on, I think, and quite rightly, because we don't talk about it often enough. I would like to thank the RSM and to say that the next COVID-19 webinar is next Thursday, and it will explore media and reporting during the pandemic, and it will be chaired by Victoria MacDonald from Channel 4 News and featuring Ivan Brown, David Oliver, and Robin McKee. So I'd like to say thank you to everyone, and it's been a great pleasure and privilege. And do, as Kate and Éamonn have said, be advocates for healthcare in prisons and ensuring that people get the healthcare they need. Because as Kate has pointed out, and Éamonn as well, a number of people actually in prisons are there because of the mental health conditions that they actually have. And that's often not recognized. So thank you very much, everyone, and good luck. Bye.
Thanks, everyone.
Thank you.